Presenting a new series, Medically Verbal, where we'll solve case history in just a couple of minutes. Disclaimer: these case studies are for understanding purposes. Inaccuracies may be present. Do not attempt these processes without the guidance of a licensed medical professional. Case 20. Chief Complaint. A 25-year-old female presents with a history of recurrent abdominal pain. History of present illness. The patient describes intermittent episodes of abdominal pain over the past year. The pain is typically in the lower abdomen, crampy in nature, and worsens with meals. She also reports alternating diarrhea and constipation during these episodes. There is no significant weight loss, fever, or rectal bleeding associated with the pain. He doesn't have a significant medical history. He is currently on no medications, occasionally consumes alcohol, doesn't smoke. Mother had irritable bowel syndrome. Physical examination shows BP 120 systolic, 70 diastolic, heart rate 78, respiratory 16, temperature 98.2. Abdominal examination presents with mild tenderness in the lower abdomen, no palpable masses or organomegaly. Initial differential diagnosis: irritable bowel syndrome, inflammatory bowel disease, gastroenteritis, peptic ulcer disease, diverticulitis. Based on this presentation, what do you consider the most likely diagnosis and what further investigations or management steps would you recommend? So with the history and symptoms, we could think of irritable bowel syndrome. For further investigation, we'll perform a fecal calprotectin. Elevated levels would suggest inflammatory bowel disease rather than an irritable bowel syndrome. We'll perform blood test. If the fecal calprotectin levels are elevated, that means there is inflammation present. So we'll perform a blood test, and elevated CRP and leukocytosis would add up to the inflammation. CRP would be elevated in the disease, but it would be normal in case of syndrome. Perform a pelvic ultrasound to see whether any pelvic organs might be causing out this particular disease. We perform an abdominal CT scan to check the signs of inflammation in abdomen. For management, we would ask them to change their lifestyle. We would ask them to take less of fibers, put them on a more liquid diet. We'll give them antispasmodics for abdominal pain relief and laxatives or antidiarrheals for the constipation as it would be required. We'll schedule a regular follow-up so that we could monitor the symptoms and see the prognosis of the treatment and accordingly change it. What is the difference between inflammatory bowel disease and irritable bowel syndrome? Inflammatory, with the name, it suggests that there is some sort of inflammation present. There is some sort of pathology that is involved. But in case of irritable bowel disease, we know that it's irritable. Why C-reactive protein is used for checking the difference. This is not the first case of bowel disease which we are seeing in this channel. I would like to talk why C-reactive protein is normal in irritable bowel syndrome and why is it elevated in the inflammatory bowel disease. Because irritable bowel syndrome is a functional gastrointestinal disorder. It's not an inflammatory condition. Irritable bowel syndrome shows symptoms like
Hope you like the case study of today. You can come back whenever you want to sum it up. Please make sure that this is not a substitute of medical advice and is just for understanding purposes of how to diagnose and solve case histories. Thanks for watching.
As we know, it always increases in case of inflammation. Directions or suggestions, comment down below. Make sure to like, share, subscribe, and hit the bell icon to never miss another update.